Hi everyone. To the situation we are now dealing with, we have to do our meeting in this way. I hope you enjoy it too. And I'm going to start with a question. Have you ever thought what would you do after you finish your degree? Psychology career has many theories, areas and population to work with. And usually psychology students start or choose the clinical or the education area. Nevertheless, there is many ways to practice psychology. And in this meeting, I'm going to explain my way. My name is Mariana Rola, and I work for Educat. In Educat, we are specialized in the treatment of ADHD, but we also can address any special education need. This is because we think there is a wide spectrum of common behaviors whenever there is a situation of failure or poor educational performance. Our method is based on the improvement on the academic performance, combined with an intervention of the behavioral, socio-emotional, and family aspects within the disorder or educational need. But we also make an attempt to improve the school motivation and self-esteem in the student. Let's remind a little bit about what is ADHD. This is a neurobiological disorder characterized by attentional difficulties, impulsivity, and/or an excessive degree of activity. These symptoms have an important impact on the academic performance, socio-emotional skills, and family dynamics. According to the last researches, it has been confirmed this disorder affects up to 5% of the juvenile Spanish population. This is a significant number, and this is why we thought it was a good way to start working with this disorder. It is fundamental for the diagnosis of the disorder to correctly evaluate all the nuclear symptoms that I said before. Also, it is important to notice if the intensity and the frequency of the symptoms are higher than normal for the child's age and stage development. Also, the deterioration or they interfere significantly in the child's performance in two or more areas of life, school, family, or all the aspects that affect the disorder. Important not to cause any other medical problem or drug or any other psychiatric disorder, such as any other psychiatric disorder. Despite the fact there are many, or they may be a suspicion in children under 6 years, the diagnosis requires having exceeded this age. In addition, ADHD is frequently recognized in children when they start primary school, coinciding with the difficulties in the school performance and presentation of social dysfunctions. That's a difficult word for me. The core symptoms of ADHD that I said before are independent from each other. In fact, not all the children with this disorder have the same symptoms and the same intensity. This is not a manual disorder. It could change in the intensity, in the frequency, and in the presentation of it. And it could be combined with another disorder. There are 3 presentations distinguished in this disorder according to the DSM-5, the Diagnostic and Statistical Manual Mental of Disorder. No, the Diagnostic and Statistical Manual of Mental Disorders. I hate that name. Predominant inattention, that is the difficulty to maintain the attention, and in fact, there is a prevalence more than in girls from boys. Also, we could find the predominant of hyperactivity or impulsivity, There is the excessive degree of energy and or the difficulty to control the impulses, and we can find both. They present all three nuclear symptoms: impulsivity, attention difficulties, and excessive degree of energy. These kids, the combined ones, are the most difficult ones to work with, because you not only have to work with the attentional difficulties from school and trying to make a routine, but also you need to work with the family dynamics, because the family dynamics is very affected in this type of disorder. The prevalence of ADHD is high. In fact, it's one of the most frequent childhood psychiatric disorder, ranking above others. In the world, the overall prevalence is estimated to be 5.29% in school-age children. In Europe, it's estimated to be 5% of the children and adolescents between 6 to 17. But only in Spain, the last studies suggest that the prevalence is 6.8% of the children in school age. This number is very significant, and we thought a little bit, why is this, why there is a high prevalence of this disorder? This is because the data is suggested by the clinical criteria, and it might vary over time, and also depends on the evaluation method, the diagnostic criteria, the type of sample, the social cultural aspects, and more. So it could be overdiagnosed, but also underdiagnosed. And this is why it's difficult to maintain a common treatment or a common thought about this disorder. Despite the high prevalence of ADHD, we have found us in a social reality of ignorance about this disorder. In fact, in a study conducted here in Spain, with the objective to knowing the degree of knowledge about ADHD, the results shown a 4% of the survivors recognize the terminology ADHD, but 33% of them considered the disorder is due to disorganized family or environment or school. And this is not true, because we have found with families that, they have a little bit of a disorganized family, but also the disorder affects to disorganize this family. So it's not always because of that. It's not always due that. Despite, but also many professionals such as psychiatrists, teachers, and even psychologists such as us still believe ADHD doesn't exist. This lack of training, information, and care about the disorder has a direct negative consequences on these patients, their families, and their social circle. This turn causes a stigma, an insensitivity, and a lack of consideration with the person who suffers the disorder. This is why we think it is important to organize everything about this disorder. All the professionals working together, or the medical population and human health population, we need to work together. We need to organize it. We need to address all the facts about this disorder and conclude something, because it's still in the air, and some people don't believe it exists, and some people still do believe it, and some people work with it, some people work with other things because they think it doesn't believe or it doesn't exist. So we need to combine all the thoughts, all the information, all the care, and address one objective together. Let's think about where ADHD come from. So, due to the complexity of this disorder, this or ADHD is considered heterogeneous, with a different subtypes. That's what I said before. And it's the result of different combination of various risk factors working together. So, it has been identified that the causes of the disorder are due mainly genetic or environmental factors. Environmental factors are considered, among others, like traumatic injuries in childhood or in adolescence too, but a little bit. Infection of the central nervous system, also low brain weight or birth weight also, consumption of toxins during pregnancy, such as alcohol, drugs, tobacco, and many other environmental factors. But this doesn't say us anything, because these environmental factors are or do explain many other psychiatric disorders. So this is not a good way to explain it, or a good origin to explain why ADHD exists. But also, some studies have found a 76% of chance of heritability from genetic factors. There have not been any study who choose a factor, like a genetic factor instead, or a genetic factor, how I'd say it, a genetic factor per se, I'm going to say that, but a study have shown that family members of ADHD have 5 times greater risk than people with no history of the disorder. Many of the children we work with, their parents have ADHD, but they didn't know. Or when they start to notice in their child some symptoms they couldn't explain, they said, when I was a child, I usually was like that, or behaved like that. Why he is behaving like that and nobody treated me? And they start to believe that these children need a little bit more of consideration, different treatment, and more patient, more than everything. And they start to understand things they do and how they behave, and because of the child, so they change. And this is an interesting fact. Also, some recent studies have found a neuropsychological or neurological common alterations in brain structures, which cause deficiencies in the executive functions and emotional difficulties. These alterations are reflected in the capacity to maintain the attention, ability of planning, memory work, cognitive flexibility, and inhibition. The executive functions is the most important area, or the most important ability of the brain that we need to work with in children with this disorder. But the inhibition is reflected mainly in the emotional recognition and the emotional expression, totally in the self-control of the emotional management. And this is what we notice more. This is the inhibition part is more noticed in the emotional area, and that's the sign of alarm that the parents contact us, or used to contact us. Also, we have found motivational difficulties, and That is why they usually want external rewards immediately, and they're experts to postpone their duties, because if they don't receive an external reward at that moment of the behavior of the duty of their parents want to, or the school wants to do, they try to postpone or do another thing they're found more pleaseful. Also, what I said before, this disorder have how to say it, a bigger chance to a comorbidity with another psychiatric disorder. It's frequently presented with anxiety, with conduct disorder, with a conduct disorder, with a challenging negativist disorder. That's a very difficult word. Challenging negativist disorder, and or mood disorders. The study have found a comorbidity of 70% of children in ADHD that have ADHD. That's a very huge percent of cases. But also could have an additional impact in the quality of life. When you have an ADHD that is comorbidity with another disorder, the impact in the quality of life is bigger and is more difficult to work with. This usually cause low self-esteem, school failure, social problems, substance abuse also, and mediocre disorders. Why I said substance abuse? Having ADHD is a risk factor to substance abuse when they are bigger, because they found in alcohol or in drugs a way to manage their behavior, their feelings, and their stational. And this is why we have found many cases that have both disorders. When ADHD is associated with another disorder, the diagnosis is frequently more complicated, the evaluation is worse, and the response of the treatment is less. Let's start a little bit of the treatment of this disorder. ADHD involves 3 approaches of treatment: pharmacotherapy, cognitive behavioral therapy, and psychoeducation with parents and teachers. Studies have shown the best approach is a multi-dimensional treatment or multimodal treatment to reach every area affected by the disorder. This will imply several professionals working together side to side. So, if we start with the pharmacotherapy treatment, we have found many drugs to work, but they usually work with their 2 main symptoms: attentional difficulties or impulsivity. Those 2 symptoms are the most frequently treated with the pharmacotherapy treatment, but it has to be combined with a cognitive behavioral therapy or a psychoeducational therapy. Only pharmacological therapy doesn't do anything in the patient or in the child who is suffering the disorder. The cognitive behavioral therapy is recommended as an initial treatment of the following cases: ADHD symptoms are mild, ADHD has a minimal impact of the child's life, or when there is a discrepancy in the frequency of the intensity of the symptoms between the parents or the teachers, the diagnosis is uncertain, or the parents are not agree with a pharmacological treatment. So, the cognitive behavioral treatment is a way to start. When the symptoms are affecting a lot the child's life, the quality of life, we could think about approaching also with a pharmacotherapy treatment. But not all the cases of ADHD need a pharmacotherapy treatment. Also, we as Educat, insist on the importance, we insist on the psychoeducational treatment because ADHD cases with repercussion in school environments need this type of treatment, focusing in the teaching academic skills and competences which take into account to the student. Further studies have revealed or have released the most effective method to reduce nuclear symptoms, attentional difficulties, impulsivity, hyperactivity, and self-esteem and motivational difficulties is the pharmacological combined with a cognitive behavioral therapy or psychoeducational therapy. That's what I said before. But also, it's important to remind what I said like 2 minutes ago, that not all the children who has this disorder had mainly take a pharmacotherapy. If the symptoms are affecting the quality of life of the child, and the child, it's the dynamic, the family dynamics and the school dynamics, it's falling apart. That's where we think about adding a pharmacotherapy, a pharmacological therapy. It has been shown that educating the patient and the family about this disorder can help obtain better results. What we do? Our intervention is psychoeducational. It's not a cognitive behavioral therapy, it's psychoeducational. But we also address some of the techniques of the cognitive behavioral therapy. Our session is an afternoon, usually after school, and approximately lasts 2 hours. And we repeatedly once a week or twice a month. We usually start the session working with the academical area, using their own school material, teaching study, organizational, and planning techniques. I'm going to drink a little bit of water, sorry. Okay, we do this, we teach studying, organizational, and planning techniques to improve the executive functions and the school performance. This area, that we call the academic area, usually lasts between 60 to 90 minutes. And then we check with them how was their week. With the emotional part of the disorder, we try to talk to them and if they have any problem with a friend or with a family. And we try to approach an emotional language, emotional management, and emotional recognition. That's the 3 parts we think is very important within this disorder. And finally, we talk with the families and intervene in the problematic situation within the disorder. And we teach them some cognitive behavioral therapies, such as reinforcement or punishment, to add or reduce some behaviors that are problematic for them. Furthermore, and we think this part is very important, we work side to side with the school the child is attending to. So we also offer some tutorials for the children, the counselors, and the orientational department to let them know what we are working and what we need from them. we think this part is very important because we need to ensure the language we are working with. How, as I said before, we have found us in a social social reality of ignorance that some children, some teachers, or even psychologists still doesn't believe ADHD exists. So we try to make them think as we think, and trying to make them recognize the symptoms we are looking, or we are reaching in this disorder on this child that we are working with. In Educart, we agree with the concept of combined treatment to reach every area of the patient life: school, family, and personal. Such as an example, I could tell you about two cases that have been very, very difficult for me. One of them is a boy that has 10 years old. He has ADHD combined, the type that has the three symptoms, but also they have a comorbidity with a negative challenging negative disorder. I have been working with him for almost a year, and the improvement has been, you have no idea how much. But when I started working with him, he couldn't be in a chair for more than 30 minutes. He never finished any school duty because he wouldn't write. He didn't want to write anything. He thought it was aversive for him, and he went to school for 2 months, and he didn't write anything in his book. That was the first alarm signal that the mom talked to us. But also, he was a little bit challenging, and he had some how to say it. He had how to say it. Reactions of irritability. He has also a need to play with the consoles, like such as Nintendo Switch or he has a tablet and he plays a lot with the tablet. And when you told him, or when you tell him to finish that that moment, like the play, he starts to irritate and be very angry and start hitting and pushing and screaming. And also that happens at school. 2 months after I start working with him, we have a reunion with the school. In fact, this is the case that I have been more, they had more teachers counselor, like school reunion with me. And the school told me that the anger excited, when he was irritable, had minimized very, very much. And also he learned to, when he started to feel angry, he said, please let me 5 minutes. He goes to the bathroom, breathe, and he comes back to the classroom, and he's cool to continue with the dynamic of the classroom. The teachers told me that it was impressions, and I was very happy he managed to do that. And also the mom told me that he started to write in the books. Or in fact, he do many of the school duties. He's a little bit behind, but he's right now doing all the duties. And now in this moment of quarantine, we are working by Skype, and it's very funny because he's one of my cases that could be more time with me in Skype, and he do everything I told him without any challenging, and he managed very good everything I said. He's very intelligent and very mature for his age, so he arranged everything I said to him. The other case that I would like to talk to, it's a 14 years old boy also, that it doesn't have ADHD, but he has a special education need that he is the most challenging adolescent that I have, because he knows he wants to be good at school, but he postponed everything, and he still does. He still does it. He is working with the school side to side, because the school is working is very good working with me. I have been in 2 reunions with the school counselor, the orientational department, and the teacher, and the school is very attentive to him. But also, the mom has made him to be in 3 types of school activities, such as a physical and chemical teacher. He has a math teacher, and he has me. So we have 3 people working with him, also the school and also the mom. The mom works a lot, so she doesn't. She has no time to be a lot with him, but she tries, and this is why we trying to be with him. Many professionals try to be with him, but he still doesn't manage his school duties how he's supposed to. He doesn't have any difficulties. He has a little bit of attentional difficulties because he gets bored, and he doesn't like very much school. He has a very low school motivation, but he has that differ between I want to proceed and I wanted to have a good school performance, but the other way I said I have a English assignment that is very long and I don't want to do it, and he doesn't do it, and I'm still working with him, and I have been it has been very difficult to me, or for me, to improve that school motivation. Even though my bosses and I have had 2 meetings with him and his mom at the same time, as an intervention, as a family intervention, that he said he compromised with the things we told him, but the next week he blew it up. At this time, we are working with more than 120 families, and our team has grown from 5 to 15 psychologists in just 3 years. We also have a neuropsychologist in our team, and work with some schools and ADHD associations. We think our team has grown this much because there is a need that haven't been approached yet. Our team also does public meetings with the school centers to talk about the disorder and our method and why we think it's important to work in a multimodal way. Also, we explain why we think it is very important to work with the school motivation and the self-esteem of the child. We annually attend to the ADHD annual meeting to perform speech such as an specialist in this disorder. Finally, I would like to say we are also working in some new projects such as social skill workshops and a social meeting group named Ocio Joven to improve our reach to the older population affected by this disorder. In the social skills workshop, we try to improve our reach in the emotional area of the disorder. We have a group of children. We have a group of adolescents, but we also have a group of children under 12 years old. The professionals who works in each of the workshop try to teach them emotional management, emotional language, and recognition of the emotional recognition. Also, it's very interesting because they have a social group that is like them, and they reach more people that are they have the same symptoms as them, and they learn how to deal with how the other guys or the other girls deal with their problems, and they learn all together. In the social meeting group, we have teens under 18. We have 7 boys, and we try to do some social meetings, such as bowling or escape room or movies, something like that. To these children we work with, well, not children, adolescents we work with, has many social problems, and they don't have many friends. So we try to create this group to improve their social area, their social group, and they could learn how to interact with other guys from the same age. We are trying to make a girl to come to the group that is under 18 also, and to let them learn how to interact with another girl, and also that. And this is a very good group also. Right now we are working by Skype because our sessions our sessions couldn't be done at homes. I didn't say that before. We don't have our clinical area. We don't have I don't remember the word. We don't have like a place. We go to the children's houses, and that's another reason why the families prefer us from another groups of professionals that work with this kind of disorder. Finally, I hope I answer some of the questions we struggle with such as psychology student, and also I hope I create a new perspective about ADHD disorder, and you learn a little bit more about this, and maybe I create a little bit of intrigue about what we could do when we finish our degree, what we could do finally when we are able to practice our profession. We are not a clinical area. We try to make a difference. But if I would like to say this also, if we found a psychiatric problem that is about our reach, about our abilities, we contact with another psychologist or professional to work with that problem, and then we start working again with a person, because there's some clinical facts or problems that we are not able to reach. I think that's it. I hope you enjoy this meeting that we have right now, and I hope I also create that that small spine that with why we think ADHD is a disorder very important to treat and very important to deal with. Thank you for listening and have a good day.